Hi, everyone. Welcome to our next session in our Boosters and Beyond series, addressing key challenges. As you know, with this series, we are tackling the CDC's core infection prevention and control practices for safe healthcare delivery in all settings. This week, we're going to be talking about patient, family, and caregiver education, and Laura Benzel is going to be our esteemed speaker today. Next slide, please. So if you're not familiar with who we are the IPRO QIN-QIO. IPRO holds the federally funded Medicare QIO contract for the 12 regions shown here. IPRO specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the IPRO QIN-QIO banner. So if someone asks you if you know who IPRO is or if you're working with IPRO, you say yes. Next slide, please, and we'll pass it over to Mary Ellen to talk about our COVID-19 updates.
Hi, Josh. Thanks, everybody. Good to see you virtually. Just some information on COVID. Hospitalizations are down again this week, which is good news. 7-day average, a little over 4,000. Bivalent booster ticking up little by little. We're now over 51 million people who have received the booster dose and have gotten to a little bit over 40.1% for adults older than 65 receiving that updated bivalent booster. Variants have been the same. Nothing's changed with that. Next slide, please. Just a screenshot of the NHSN vaccination data for nursing home residents. We've hit the 50% mark. Yay! So again, we're ticking up very slowly, and despite all the COVID vaccine fatigue, just want to give a shout out to folks. I know you're doing a great job under very difficult circumstances to move these numbers, so much appreciated. Next slide. Just a quick update. The FDA had their advisory committee meeting last week. They talked about a number of things, but primarily the future of COVID-19 vaccines. So more discussion to come. They all agreed on that the COVID-19 vaccine schedule needs to be simplified. And I think we could all agree with that. The question is, how is that going to look? So there's a lot of talk about a once-a-year COVID booster shot. What would it look like? Who are the populations we should target with it? So we'll keep an eye on this and provide more information for all of you, but that discussion started last week. The other is, I just point you to a new infographic that CDC put out last week through the MMWR. I think, Josh, if you can't put it in the chat, I can put the link into a really nice infographic on a COVID-19 action plan. They've talked about this in the past, but this is a lot more visual as far as prevention measures in addition to being vaccinated that people may just want to keep in their back pocket when they're looking at their own risk in different situations. So really nice infographic, and we'll share that. I think that's it.
Perfect. So thanks so much, Mary Ellen. And again, we have Laura Benzel here to talk about patient, family, and caregiver education through a lens of health equity. Over to you, Laura.
Great. Thanks so much. It's great to be here today, everyone. As Josh mentioned, I would like to talk today about the importance of patients understanding health information and the implications if they don't. So there's a lot of research out there that shows that patients often misunderstand health information and instructions. And, sometimes providers have the assumption that what they're saying is clear and that patients can understand those complex written and verbal information, but the case, the research shows that's not the case. And when that happens, patients are unable to make the right decisions or to make the necessary actions for optimal health. So if we look at this slide, it's just an overview of some of the factors influencing patient understanding. So low health literacy obviously is a major cause of misunderstanding of patient information or medical information. And I should note here that general literacy does not equate to high health literacy. So you can be someone with an advanced degree and still go to a doctor's office. And if you have a serious illness, as an example, and you're being hit with all this information, you still may not understand what's being said to you. So that's important to point out, is that we can't assume that someone who's highly educated or who seems quite literate has health literacy skills. The next one is cultural and linguistic factors. Obviously, if someone is not, English is not their main language, so limited English proficient patients will have issues understanding and comprehending medical information. And there are also cultural beliefs. Certain patients may have a belief about the way they want to be treated, and so they may not understand or may not embrace the protocol that a provider is telling them. And lots of times as a patient, you may not feel comfortable admitting that you don't understand. So a patient may sit there silent, even though they're not understanding what the provider is saying. And that's why it's really important for providers to confirm patient comprehension. Lots of times that doesn't happen. There are also patient sociodemographic factors that influence their comprehension. So if you're someone who's worrying about food, where you're going to get your next meal, if you're housing insecure, if you have lower educational attainment, all those things are going to affect your ability to understand and be able to implement protocols or medical information from a provider. And obviously the last one is pretty obvious. We have a complex healthcare system, so navigating that can be very difficult for many patients. So this is a definition of health literacy from Healthy People 2030. You may have seen this. Health literacy occurs when a society provides accurate health information and services that people can easily find, understand, and use to inform their decisions and actions. Healthy People 2030 also distinguishes between personal health literacy and organizational health literacy. So obviously the first one, as I just mentioned, is the ability of an individual to go out and find the information they need to make health-related decisions. But there's also an onus on organizations to equitably provide that information so that patients can understand it and use that information. So it's really, both patients and organizations have health literacy skills that they need to hone. So there's a recent report from the Milken Institute. This is really the most recent that I have found. It's dated 2022, that talks about health literacy in the United States. And you can see this as a pretty overwhelming statistic. They determined that 88% of adults living in the US have health literacy that's inadequate to navigate the healthcare system and promote their well-being. And what they did is they went out and did a review of literature dating back as far as 2007 up through the current times to come up with this statistic. So they really did a detailed analysis. I do have the link to this report. It's a great report. If you want to find out more about health literacy, the link is there on the slide. And I think Josh is going to be putting it into the chat as well. So this is just three prominent studies that were included in the Milken report in their assessment of health literacy. You may have heard of the first one, the National Assessment of Adult Literacy, that took place in 2003. It really was a groundbreaking study because it was the first one that actually looked at literacy as well as health literacy skills. And so that's a pretty significant study, and the other two I'm including as well. There are many out there, but I just wanted to give you access to these three if you're interested in learning more about the research around health literacy. So I'm going to pause here, and I have a question for all of you. What are some of the consequences when a patient doesn't understand health information? If you could think about that and put your responses in the chat. We will revisit this a little further along in the presentation, but we'd love to hear, get your responses to this question. What are some of the consequences when a patient doesn't understand health information? So I mentioned earlier that cultural and linguistic factors can affect a patient's ability to understand health information and also implement protocols from a provider. So cultural and linguistically appropriate services, also called CLAS, improve the quality of services that you can provide to individuals. So CLAS helps make healthcare services more understandable, more respectful, more effective, and more equitable. And ultimately, it's to help reduce disparities and achieve health equity. So let me give you some examples of what we mean by CLAS services. So as a healthcare organization, you may hire bilingual and bicultural staff. And so that helps patients feel more comfortable and improve that communication between provider and patient. You may have trained medical interpreters for all encounters. I mean, that's key. That's like a best practice, is that you're prepared to help patients with limited English proficiency during an encounter. You may also have qualified translators available to translate materials that you're providing to patients in the preferred languages. And the way you do that is by collecting race, ethnicity, and language data and assessing those language preferences and then providing those materials in those languages. Another example is you may develop a language access plan to ensure that you're effectively communicating with individuals. So those are just some examples of CLAS. So along those lines, we are actually launching an initiative to advance culturally and linguistically appropriate services. We're offering an assessment that you can use to help you to determine where your organization may be in implementing CLAS. The link is on this slide here. We're also starting an educational series that'll kick off on February the 8th. We are going to have 8 30-minute sessions around CLAS standards that are from HHS. So you may have heard of their website, Think Cultural Health, where they talk about CLAS standards. We're going to be using all of the information from HHS in our educational series to help facilities develop an implementation plan to identify and address opportunities for improvement in delivering CLAS. So we hope you'll join us for that. So just let's go to our chat and review some of the responses that you put in there regarding our question about the implications when a patient doesn't understand health information.
Sure, Laura. So we actually got quite a few responses into chat. So again, the question was, what are some of the consequences when a patient doesn't understand health information? And we got a response: rehospitalization, so a patient being sent back to the hospital. We have another response: taking their medications incorrectly. And I'm just going to keep listing them off here. Poor choices being made. Not understanding can lead to medical and health decline. Unnecessary fear of healthcare, lack of follow-through, medication errors. Patient can be misinformed if they're misinformed, they may not fully understand the benefits of what was being offered to them, which can be detrimental for the health. Non-compliance with care plan from a lack of understanding. Ultimately not being able to make the best decision and negatively impact their life and their families, or not even be able to make a decision at all.
There's some there that I hadn't even thought of, so that's great. They're all right on the money. Obviously, the most critical concern is adverse events and patient safety events. If a person doesn't understand, and that can lead to some pretty significant results. You already mentioned poor health outcomes, increased hospitalizations, greater use of emergency services. Poor medication adherence was mentioned several times. And also we find patients that have lower health literacy or don't understand information have lower uptake of preventive care. So that was a great review of what can happen when patients don't understand health information. Thank you for that. So I am going to now go over some data that we thought you might find interesting that IPRO has pulled together. It's nursing home data that we stratified by certain health equity elements. And this is for the nursing home beneficiaries in the IPRO network, our 11 states in the District of Columbia. So we use this data to create some charts, and just an FYI, this data is as from November 2022. So this first graph is showing race and ethnicity for long-term and short-term stay beneficiaries. So you can see here it's pretty equally divided. Most residents are white, non-Hispanic. There are slightly more non-white residents that are in long stay versus short stay. So this is just a breakdown by race and ethnicity. This slide or this graph is showing race and ethnicity of nursing home beneficiaries by, again, those states in the IPRO network, our QIN-QIO network. You can see there are significant differences between states in the percentage of beneficiaries that are racial or ethnic minorities. For example, if you notice DC further to the bottom there, DC nursing home beneficiaries are predominantly non-white, 85%. And DC also has a significantly higher percentage of Black nursing home beneficiaries at about 82%. 98% of Maine, Vermont, and New Hampshire nursing home beneficiaries are white and non-Hispanic. However, it's important to keep in mind that health disparities exist beyond race and ethnicity, which we'll talk about in a minute here. There are other factors to consider when thinking about disparities, including age, gender, disability status, and social determinants of health. So this table, our analysts compiled this table for the IPRO nursing home beneficiaries using the CDC Social Vulnerability Index, also called SVI. The SVI estimates are derived from 5 years of the Census Bureau's American Community Survey data. So we ranked our nursing homes into quintiles based on the assessment of 4 SVI themes, and those themes are socioeconomic status, household characteristics, racial and ethnic status, and housing type and transportation. So a low rank indicates less vulnerability, where a higher rank is most vulnerable. Those 4 themes were then combined to create an overall ranking by county of the nursing home. And the overall ranking was then put into quartiles. So for this particular table, there were some key takeaways. 65.1% of the IPRO nursing home beneficiaries fall into the most vulnerable quartile of social vulnerability. Not shown on this table, but I did want to highlight it's 26% female and 39% male. The highest proportion of beneficiaries residing in areas of the highest social vulnerability are white non-Hispanic at 49.3%. Black beneficiaries comprise 14% of our cohort. However, 12.2% of those beneficiaries are residing in nursing homes with the highest social vulnerability. And Ohio and New York have the most beneficiaries residing in nursing homes with the most vulnerable SVI quartile. So this graph shows socioeconomic status by race and ethnicity. Some key findings from this graph is that 84% of Hispanic beneficiaries are in a nursing home with the highest vulnerability for poverty. This is followed by 79.4% of Black beneficiaries. So if you take those 2 racial and ethnic minority groups and compare it to white individuals comprise 52% of nursing homes in the most vulnerable for poverty. So we see a disparity there between racial and ethnic minorities and white individuals. A higher percentage of white beneficiaries are in nursing homes with the lowest vulnerability for poverty. So again, we're seeing a disparity that whites are in nursing homes with the lowest vulnerability compared to racial and ethnic minorities. So this table is showing the percentage of nursing home long stay residents during the influenza season who have received an influenza vaccine. So our baseline is March 2021, and compared to the baseline in March 2021, influenza vaccinations for all racial and ethnic groups was lower in November 2022. It's the same for male and female beneficiaries. So some other key findings is that male nursing home residents are less likely to receive the flu vaccine compared to females. We also found that Black residents are approximately 10% less likely to receive the flu vaccine compared to white residents. And also Asian residents had the highest rate of flu vaccination. So this next slide is a continuation of that table. I couldn't fit it on the one slide, so I had to split it. And we find that across all states and geographic regions, again, we're seeing that the influenza vaccine rate is lower in 2022 compared to baseline. This particular graph shows the percentage of nursing home long-stay residents with a pneumococcal vaccine that's up to date. So compared to our baseline, again, in 2021, pneumococcal vaccinations for all racial and ethnic groups was lower in November of 2022, except for Asian individuals who had no change. And we see the same based on gender. It was lower. We see lower uptake in November of 2022. Couple other key takeaways is that male nursing home residents are less likely to receive the vaccine compared to females, and Black residents are less likely to receive the vaccine compared to white residents. And this is the second part of that chart, and we see here that the table shows that pneumococcal vaccination for long-stay residents by state and the District of Columbia, and also geographic regions, pretty much across the board here, we're seeing no improvement except for Delaware and Massachusetts. They did show an improvement, but again, across all the other states and geographic regions, we're not seeing an improvement in pneumococcal vaccination. So I included this slide. This is just a description of that SVI, or Social Vulnerability Index, by the CDC. I thought it might be of interest as to how we used it. This is a little more information that came from the CDC website, just for if you want to learn more about it, I included it. So we talked about all of these factors that can influence a patient's understanding of medical information, and we'd like to now provide some tips for providers. Obviously, using plain language, limiting information during a clinical encounter to just 3 to 5 key points, repeat and summarize for patients, use the teach back and show me methods. And I have a resource from ARC that AHRQ that gives you information about those particular methods if you want to learn more about them. I think teach back is a method that's been out there, so probably pretty much everyone knows about that one. Another recommendation is to demonstrate, draw pictures, or use models with patients. Be very specific and concrete, not general. And also create easy to use patient materials in languages that are congruent with your patient population. And I included this quote that came from the AHRQ resource, which clear to you is clear to you. So we just have to keep that in mind. We can be saying something that we think is clear, but it might not be the case for the recipient. So I'm going to hop out of the presentation and bring to your attention a tool that you can use to run your text through that will give you an idea of how difficult the language would be for a patient. I'm going to be using the text from this particular resource from APIC on infection prevention and you. So let me stop sharing. You should be seeing the Flesch-Kincaid calculator.
Yep,
and
perfect.
Okay, thank you. Sorry for the maneuvering there. I lost it for a minute. But what I did was I took the text from that resource that I just showed you, and I pulled it out and put it into this calculator. All you do is cut and paste. So if you're creating a brochure, for example, you can take your text and just paste it in here. And then it gives you a rating of how difficult this particular text is. And you can see that they're rating this one fairly difficult to read. The reading score is 59.58. The higher the score, the more easy it is to comprehend the text. You can see the grade level is 8.23. The recommendation, the best practice is that you keep patient material at a 5th grade level. So you can see this is pretty high. And the reading level is 10th to 12th grade. So if you put text in and you get these kind of readings back, you may want to consider making the text easier to read and going through it and just making sure that it is the easiest for patients to comprehend. So this is a nice tool that you can use. There are several out there, but I've included a link to this one on a resource page. So I just wanted to show this to you because it's a great tool to help you when you're developing information for patients.
Or even having a good understanding of the information that we're giving the residents. The resources that we're currently giving wouldn't be a bad idea to run through that calculator to see, oh, the stuff that we're giving out has that higher reading level. So we may need to come up with different resources to send or change it up a bit. So I think it's really brilliant. Thank you, Laura.
Sure. So these are just some resources I wanted to bring to your attention that you might find helpful. This is the link to that calculator. And that's it for the presentation. So I will turn it back over to you, Josh.
Thank you so much, Laura. So I did put the link to that calculator into the chat for those who may be interested in taking a look at that. And once the slides are 508 compliant, they should be available for anyone who's interested in having the slides to review the information. But at this point, we'd like to turn it over to you in the audience. If you have any questions for Laura, our subject matter expert on health equity, it's really good opportunity now to ask her any questions that you might have as it relates to health equity and educating your residents and families and caregivers. Feel free to come off mute or put it into chat. So I'm not seeing anything so far in the chat, and nobody's coming off mute. So that'll be it for today's session. So if you know anyone who would benefit from today's session, the session was recorded and will be played again tomorrow at 3:30 for anyone who might have missed it. We also have our IP3 session this Thursday at 11. So we welcome you to join us for that session. And if you have a second before you close out of the meeting today, if you thought this session was beneficial to you, helpful, we really would appreciate some comments on your way out into chat if you thought the session was helpful. And I'll just leave up the session for a couple minutes to allow you to do that before we close it out. Thank you so much, everyone, for your comments. We really appreciate it. And that'll be it for today's session. Thank you so much.